Good morning from St. Bart's in Midtown Manhattan. My name is Peter Thompson. I serve as the vicar here, and it is my joy and delight to welcome you to the forum, where each week we explore important issues at the intersection of faith and the modern world. Today, we're celebrating St. Luke's Day. St. Luke was thought to have been, in addition to a gospel writer, a physician. And so today we are praying for healing, continued healing amidst this COVID-19 pandemic. And we are also recognizing all who work in healing, those in the healthcare field who have done so much over the past year and a half. For this forum, we are really honored to have with us 8 members of the St. Bart's community who themselves work in the healthcare field. They aren't the only members of St. Bart's who work in the healthcare field, but they are representative of many St. Bartians who do this important work. And we are looking forward to highlighting their work and hearing about their experiences and insight into healthcare as we continue to face this pandemic. First, I'll introduce the participants who are joining us this morning. Dr. Catherine Belford Budd is a retired obstetrician gynecologist at Thomas Jefferson University. She's also been advising the rector as part of the medical advisory team. Dr. Jamie Ferrara is the Ward Coleman Chair in Cancer Medicine and Professor and Director of Hematologic Malignancies Translational Research Center at the Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai. Molly O'Neill Frank, MDiv BCC, is staff chaplain at Memorial Sloan Kettering Cancer Center. Michael Horton is staff chaplain at Mount Sinai Beth Israel. Eric Leach-Rodriguez, MSN, is Director of Medical Management at Amita Care Inc. and HIV specialist at AIDS Healthcare Foundation. Tim Martin, LCSW-R, is Assistant Director of Psychiatric Social Work Services at Coney Island Hospital. Dr. Robert Sweeney is Clinical Thoracic Surgery Fellow and PhD student in Immunology at the Icahn School of Medicine at Mount Sinai. And Dr. Patricia Tidwell, PhD, LCSW, is psychotherapist in private practice. I hope I got all of that right. It's really great to have all of you here. Thank you so much for taking the time to be with us this morning. So we'll dive right into the questions. There's a lot to cover this morning. Our first set of questions will focus on what the state of the COVID-19 pandemic is, and then we'll get into some more broader questions as we move along. And I think the first question I'll direct to the 2 members of the Rector's Medical Advisory Committee, since they have been so closely advising us all this time. So Dr. Budd and Dr. Ferrara, can you talk a little bit about the current state of the pandemic and how optimistic you are that we may someday reach an end? Catherine, how about you first?
I think we're in an interesting time. We have increasing numbers of the population becoming vaccinated, but it's been a slower course than we had hoped originally. Most Americans do favor vaccine mandates, and we're seeing more and more of those. But I think we're also realizing that the COVID pandemic is not going to have a nice sudden closure. It's going to be something that is with us for quite some time. We're going to have to continue to encourage people to get vaccinated. And in the meantime, we will have to continue to figure out how to go on with our lives in a safe manner, safe for ourselves and safe for others.
Yes, I agree with Catherine. Some people talk about the fact that we're at the end of the second wave or third wave, depending on how you count in this country. About 70+% of New Yorkers have been vaccinated. That's a good number, but not fabulous. We are still looking for herd immunity, which many people sort of peg at 75 to 80% of the population being vaccinated. But of course, young people aren't vaccinated yet. And we're a little concerned to see how things go in the colder weather when people come back indoors. Of course, the fact that most people are vaccinated means that none of us expect it to be as bad as it was a year and a half ago. But there are still pockets of areas that are not highly vaccinated, and so we need to be vigilant in that regard. But I think that in general, the increase in vaccination has been very helpful, and vaccine mandates have been part of that.
Yeah, I'm wondering if we can talk a little more about vaccine mandates. One of the things that has changed since the last time we had a forum conversation about vaccines is that vaccine mandates have become more of a reality, especially here in New York City, where you have to prove that you're vaccinated in order to attend a performance or to eat indoors. Have these mandates worked?
Briefly, yes, they have. We can now do things that we couldn't do before. The other night, I was at a concert in Carnegie Hall, sitting next to people that I didn't know, but I knew that they were all vaccinated and we were all wearing masks. And I felt comfortable during that performance. And that is just such a difference compared to where we were before. So the mandates are definitely working, and even though we'd like not to have to use them, it's a good thing that we have them, in my view.
Catherine. You're on mute, Catherine.
I would agree with what Jamie said, and also add that vaccine mandates have helped encourage many people who were hesitant to receive a vaccine to go ahead and do that, especially when they're related to work environments. So we've seen a significant increase in certain communities and work groups in terms of the vaccination rate because of mandates. So that's been a success as well.
So let's talk a little bit about the hesitation to be vaccinated. We've heard a lot about religious exemptions. There are also concerns about fertility for some women who are trying to become pregnant or women who are pregnant. Any reflections on whether it's at all warranted for there to be hesitation or reticence about receiving a vaccine?
So I guess I'll start with that. I think that there are actually very, very few warranted hesitations. Basically, the only medically valid one is that you are allergic to something in the vaccine product, and that is vanishingly rare. All of the hesitations that I've heard of have been not actually very well founded. The religious exemptions have been not particularly rational, as far as I can tell, given the major religions that we know about, since none of the leaders have come out against it. And I think that in particular for pregnant women, there are a lot of fallacies actually about vaccines. It is more protective both of the mother and the fetus to get vaccinated than not to get vaccinated. The risk is not comparing vaccinated to unvaccinated. The risk is if you're vaccinated, what happens versus if you get COVID, what happens. And all of those risk factors are about, between 500 and 10,000 to 1 in favor of getting the vaccine. So let me stop there.
Catherine, did you have anything to add?
No, I was just going to reinforce what Jamie said about the importance of being vaccinated when one is pregnant or one is eligible to become pregnant or is considering or planning to become pregnant. Basically, any woman of reproductive age needs to be vaccinated. COVID is a much more serious illness in pregnancy than not being pregnant, and has associated adverse outcomes for the fetus. It is really critical to get vaccinated. And there is, as you mentioned, Peter, some concern among people that it might affect fertility or affect the pregnancy outcome. There has been nothing to be found to support that fear. In fact, quite the opposite, that pregnancy outcomes are much better, much better in those who are vaccinated.
Thanks, Catherine. Eric.
As someone, a nurse practitioner working in primary care in an outpatient population, I've taken the opportunity when hesitancy is expressed to me, I point out that we are in a country with an embarrassment of riches, of we're choosing between different choices of vaccine. And as Dr. Ferrara said, it's not about unvaccinated versus vaccinated, it's about getting COVID and being vaccinated. So I generally turn the question back to the person in front of me saying, well, what have you heard about the 3 different vaccines? Just to see where they are, because the hesitancy might be, I don't know how to choose between the 3 of them because I've heard different things about them. And so I think that the 30-second soundbite of it is better to be vaccinated than not. And if you don't have a choice, find, which thankfully in New York we generally do, that is preferable to not being vaccinated. But I'm happy to talk through someone's specific concerns, if they're in gender by birth, if they have a certain age risk, if they are concerned about nuances between them. I can talk them through 1, 2, or 3, and that's how I address the hesitancy in my patients.
And often my understanding is it is more effective to listen to someone and let them talk than come in with an instruction about you need to be vaccinated.
Agreed, and that's where I'll answer their question of me with a question back to them, so I can actually hear what's their hesitancy behind the question, as opposed to the person who comes in. One person had already typed up the letter they wanted me to sign for the medical reason that was going to get them out of getting vaccinated so that they could go to the venue of choice. And so they had put a lot of thought into the letter, so I knew that there was something else to explore with what their concerns were. But you're correct, listening is the best way, and it takes more time, but it ultimately is in their best interest and us as a community to do that listening.
Thanks, Eric. I wonder if we can briefly discuss children and vaccines, with the disclaimer that we are taping this session of the forum in advance, so the reality might change on the ground between now and when this airs. Jamie.
So it looks like children ages 5 to 12 will be eligible probably sometime late this year. My sources say November to December. The data are now being reviewed by the FDA. I don't actually know them, but people who do know those data think that they're just like the other data, and that it is very likely to be approved on an accelerated basis sometime later this year.
What about booster shots? What can you tell? Some viewers have already received their booster shots. Some are considering receiving them. Some are not yet eligible. What is it important for folks to know about booster shots?
Boy, you could spend the whole hour just on that. But let me just say briefly, we're trying to follow the data. There are 3 vaccines. They seem to be slightly different in efficacy. So the Pfizer vaccine has already been approved as a booster. The Moderna vaccine has not been approved as a booster because those patients seem to be protected a little longer than with the Pfizer vaccine. So for example, I got the Moderna vaccine and I'm not yet approved to get the Moderna booster, but I will get the Moderna booster when it's available. I think in general, the issue about vaccines is you should walk, but you don't have to run to get your booster shot. But you should walk to get your booster shot once it is approved. And I think in general, it is better to get the shot that you got initially. There have been some studies that actually looked at a mix and match approach, but those numbers are relatively small. And so in general, the guidance is still to get the booster of the shot that you initially had.
Thank you, Jamie. What do we know right now about mask wearing? It's sometimes difficult to know whether you should wear a mask or not, depending on the context, depending on whether others you're around are fully vaccinated. Are you inside, outside? What guidance should we follow when it comes to wearing masks at the moment? Eric.
I put that question in a larger question of I want 2 out of 3. I either want to be outdoors, I want to be 6 feet apart, or I want to have a mask. So that's been my short way of explaining it to patients, to say when they have lots of versions of the question you just asked of this group, of take it because it becomes too many decisions that it's not going to fit at one rule. One size isn't going to fit all. So I try and encourage them to think if you do have 2 out of 3 for your own safety. But underscoring all of that is peace of mind. And I say to them that I wear my mask, one, because it's just easier to leave it on no matter where I am. I don't want to take it on and off every time I'm going in and out of places. But I think that peace of mind ends up overriding whatever else it is, because it's our personal choice about that. And then the science, as Dr. Ferrara said, we want to follow the data. We need to have a level of protection, and all the different ways that we do that still are valid.
Thanks so much, Eric. I know that some of you have actually treated COVID-19 patients. Those of you who have treated patients with COVID-19, I'm wondering if you can talk about that treatment process and how that's changed over the last 18 months as we've learned more about COVID. Eric, I guess you're one of those. Jamie, how about you go first, and then we'll hear from Eric.
So it certainly has changed a lot in the sense that when the pandemic began and the hospitals were overrun and we had no vaccine, we were trying to protect our patients, we were trying to protect each other. We had to have strict isolation, having these patients be in the hospital alone, sometimes dying and not being able to be with their loved ones. It was a terribly difficult time in the hospitals, and that has completely changed. So we're very happy about that. And it should be also said that not only are the numbers of patients with COVID in the hospital, not only have they decreased, but the severity of those patients has also decreased, so that our ICUs are not full. Certainly in New York, our ICUs are not full anymore, even when we've got a fair number of COVID patients in the hospital, and we have many less than we used to. So we just feel like, at least from my perspective, as a healthcare worker, that medically we now have our arms around this problem in a much different way than we did even a year ago, and that's all to the good.
Eric.
Well, almost tongue in cheek, I would say all the patients that I've taken care of, and again, I work in an outpatient setting, they have all survived, which is not a statement of my skills as a healer. It's because the vast majority of people who get COVID, the overwhelming numbers of them are going to survive. And so taking care of someone in an outpatient setting, and for us, it's been telehealth, a little bit of in-person, but the vast majority are telehealth, just for the protection of not bringing someone to the waiting room, and doing that in a way that is supportive and palliative and comforting. I mean, taking care of their physical health, making sure their airways are open, do they have the right supports and nutrition, but also their mental health. Because first impressions being strong impressions, most New Yorkers have a sense that this is not as survivable as it is. And so they want to have an appointment with me every hour in order to make sure that they're going to make it through. And I will reassure them that we are available to them at every hour. They have after. And so a lot of the care is, in a sense, pastoral care. And there are others here who can speak to that more directly than I can. But my background being in nursing and now as a nurse practitioner, being able to say what it is that will get them through and take care of them. I also want to use a moment here to say one of the treatments that I think is not as well known in the medical community, let alone in the patient community, is that using monoclonal antibodies as an outpatient, and it is even indicated as post-exposure prophylaxis under certain conditions, is something I want to raise awareness of, and we can talk about it later if there's time, but I definitely want to make sure that folks know that there is that type of treatment available if you are in a risk category. Again, because this is so survivable, let's get you the treatment that makes sense for you.
Robbie.
Yeah, I just wanted to add on to what's already been said. I think, it has, fortunately, we have seen, I think, the course of patients treated or being treated for COVID has drastically improved for the most part compared to a year and a half ago. But I did also just want to reiterate, I think our experience in New York might not necessarily be reflective of what's happening in every part of the country. We are fortunate to live in a city where the majority of patients that are eligible for vaccination have been vaccinated, and I think that's being reflected in the clinical course of our patients here. But I know some people watching may be watching from other communities that may not be in different situations. I know I've heard reports from colleagues of mine that work and live in other parts of the country that may have much lower vaccination rates, and what they're seeing in their hospitals are very different from what we're seeing here in New York. So I still say that we've come a long way, but I think we still have to be very vigilant as a community, and not let our guard down, and not let any of these advances and improvements change our vigilance.
Important reminder. Thanks, Robbie. Molly.
Yeah, I just wanted to sort of mention that for me, working at Sloan Kettering, which is a cancer hospital, which really does not, we were not burdened with an overwhelming COVID situation for a lot of reasons. They're not really selling into this call. But the temperature in general, we had COVID patients and we still have them, and we have them popping up all the time, inpatient. The temperature at the hospital has sort of come down among staff as to the sort of frantic nature of what happens when a COVID patient is admitted. And I also want to say, just because I've saw patients with COVID from the very beginning of the pandemic, that for those of us who were not really doing sort of close work with patients, I think there's also been a shift in kind of how comfortable people are coming in and out of a room where someone may have COVID, but they're not necessarily doing close contact work. And I think that was not the case in the beginning of the pandemic. Everybody was sort of on high red alert. And so it feels less stressful.
Thanks, Molly. It's great to hear perspective from the front line. We still very much are in the COVID-19 pandemic, but we have been in it long enough now that we have some perspective on what the pandemic means. I'm wondering, as we look at the pandemics of the past, and I know, or still the present, and I know, Eric, you have some experience with HIV, if we can talk about how COVID is and isn't different from other kinds of pandemics.
Yeah, I would say that's another hour-long possibility there as well. But one of the parallels that may be helpful to understand, or maybe it's just because of my work in HIV for more than 2 decades now, is that the first impression there was also a strong, very lethal impression of HIV, but that was because, like with COVID, we didn't have a test for it when the symptoms started showing up. So we had patient populations that were getting ill, but we didn't have a test or a name for it. So similarly here, the survivability of COVID was underestimated initially because we didn't know how many people, we didn't have a way of testing people. And most people here, and particularly New Yorkers, will probably remember that the only place to go to get the test was if you went to the hospital, because they were the only folks that had the limited number of tests that were here even after the test became available. So then that kind of reinforced the image that you have to go to the hospital and you're going to be ill and you're going to have this terrible thing happen. Whereas the vast majority of folks that had COVID, if we were to go back retrospectively, lots of New Yorkers had COVID and never needed to go to the hospital. They've recovered just fine at home and they're still doing that to this day. And so the survivability there, similarly, so coming to the HIV pandemic, is that one of the things that confounded it and will confound this now is that there was the stigma and political nature of it. And we have certainly seen everything. I mean, MASK is somehow a 4-letter word in certain political circles. And what has that done? And I think that has, we won't know fully what that's done and what it hasn't done until more of the history books get written, but there's definitely lessons to be learned from the importance of community activism and trying to make a level playing field so that access to care and access to vaccine is as equal as possible. And I say that also from the perspective where I don't see patients. My other employer, as you rightfully mentioned at the introduction, is a Medicare, which is a Medicaid plan. And so our members, and I see the numbers come in, live in the zip codes that are most affected, but also have the least amount of access to vaccine and potentially to care as well. So those sorts of social determinants of health became a catchphrase more recently, but they certainly played out in earlier pandemics as well.
Jamie.
So I just would like to add to what Eric just said, that this is unlikely to be the last pandemic that we all experience. Most infectious disease experts say that for multiple factors, including global warming and the increased interactions between human communities and animal communities, that we are likely to see another pandemic, not in 100 years, but maybe 10 years from now, or even sooner. And we can't tell where it's going to come from. But what we can do is to start to reinforce the public health infrastructure, which honestly has been neglected in this country in many areas. And we should start preparing now for the pandemic that is likely to occur at some point in the relatively near future. And so I just think and certainly many medical societies and groups are starting to think about how to do that, but it is given the astonishing science that we have in this country around other areas of medicine, we need to apply some of those very big brains and adequate dollars to our public health infrastructure that has not received the attention that it should.
Robbie.
Thanks, Peter. Maybe I shouldn't be answering this question because this is admittedly my first pandemic, but I think what's unique about this COVID-19 pandemic is that it happened during what we might consider the golden age of science and medicine, and we really have the fortune, if we choose to really harness it, to really I think tackle this pandemic in a meaningful way. If you think about just how quickly the scientific community was able to come together and develop a vaccine within less than a year of discovering the virus is quite remarkable, and it makes it kind of bittersweet when you see kind of the hesitancy there to adopt some of these advancements in controlling the pandemic. But I think the difference there is that we do have these advances which will hopefully help us control it better. But I think now that we do have all these advances, I think it has uncovered that it's not just about the science, it's not just about having the treatment, because we have good vaccines now, but there still exists this has uncovered other issues: access to healthcare, disparities that exist, political discrepancies that may also contribute to the prolongation of such a pandemic. So I think it's kind of highlighted maybe some other factors that go into place that kind of exacerbate an already unfortunate situation.
Finally, Catherine.
This seemed like a good opportunity to mention that we are entering flu season, and it's an excellent time to get your flu vaccine if you haven't done so already. COVID tends to take up a lot of our anxiety space these days, but it's the time of year when we need to pay attention to our flu vaccine as well.
Thank you. A very important reminder, and I'm going to get mine this week. So thank you for that, Catherine. Several of you have already alluded to the fact that COVID revealed in a bigger way than many of us had seen before the disparities that exist and have existed for a long time in our healthcare system. And I'm wondering if anyone would like to comment on how we can best address those disparities. I see no one's eager to jump in. There we go, Ravi.
I won't say that I have the answer of what's best to address them, but I think one important first step is acknowledging that they do exist. And I think disparities is one thing that it's become very easy to dismiss, especially amongst healthcare workers, because no one wants to think that they're treating patients any differently based on any number of factors. But the fact is the data shows it's very clear cut that it does exist. And I think the first step in even beginning to address any of these disparities is not dismissing that they're there, and recognizing that it is an issue, and it's a real issue, and it's one that has great clinical and social impact. But thank you for that question.
Jamie.
And briefly, I think part of the reason that we're hesitating is that at an individual, it's absolutely a problem, but it's a systemic problem and institutional. There need to be institutional answers. So those of you who are watching, who are head of hospitals and heads of medical schools and hospitals, we are looking to you to help force these changes, because honestly, the payment structures work all against that. And so we have to actively work not only as individuals, but as institutions and even society, and say we will no longer accept this form of institutionalized racism and it's not only racism, but there's definitely a large socioeconomic racial disparities, and we just cannot accept that any longer. And there has to be systemic institutional change, not only individual change.
Eric.
Like Robbie, I don't have the answer, but I did see New York City take a significant step toward equalizing the loss of work by offering paid time off, both to go get a vaccine and potentially for the side effects from the vaccine. And that may not seem like much to myself, whose employer would have done that anyway, but there are plenty of people for whom that was an issue, and particularly if they had a family large enough that they were then going to have to go back with their teenager when they became eligible, and their parents needed help to get there, right, the multiple generations under one roof. That is something that becomes a financial burden, and the city helped offset that. So that it's one of the places that I'm glad that someone thought of it, but in my many privileges in my life, I knew that I was not going to have to choose between income for the day and a vaccine. So just recognizing that reality and all the other myriad ways that those social determinants of health are really pernicious, and in almost what may seem like a nuance becomes a huge challenge that may prevent someone from being able to take care of their health.
It's good to see a little bit of progress, however small, even if it's just through a small action. And yes, this is a topic, like so many of these, that we could spend an entire session of the forum on. So it's not really fair to just give it one question. I do want to bring in our therapists and chaplains now, and first talk about mental health during this pandemic. What has it been like to provide mental health care during this pandemic? How have things shifted for your patients? And what do you see as the prognosis for the future? Tim. You're on mute though, Tim.
There's a lot in that question.
Another thing that could be a forum in and of itself.
I mean, one of the things that's changed the most, I think, for us and for where I work at least, is the way in which we provide services. Most of our interactions now with clients are via televisit, either by phone or via video. And so there was actually a time too, and even our intakes were done sort of remotely. And now we do at least the intakes in person, so that we see the patient really kind of face to face, although with a mask on and a face shield. And the psychiatrist does it well as well, just because that, I think, helps out in the connection with that person. And I think that's, I'm still kind of waiting to see how all of that sort of like turns out, because so much of the therapeutic process actually comes from that relationship that you build with the patient. But I'm glad that we have this so that we can be able to provide this, because I know there are a lot of people, I think, that have not sought out services that could benefit from it because of their fear of coming into clinics, coming into hospitals, fear of being possibly exposed to COVID, despite all the precautions that we take to try and prevent that. And I think it's just impacted them in the way that sometimes it's impacted a lot of us in terms of during the worst of it, the increased social isolation. For a lot of our clients, there are sort of like additional support systems in the community that they could no longer have access to, like psychosocial clubs. And so, I think it's still something that we're going to start maybe seeing even more of. I work with adults, but I just had a conversation recently with one of our child psychiatrists. And a week ago, I actually ran into a friend of mine who's a school psychologist. And just hearing them talking about how busy they've become in the schools with kids coming in. Now the kids are returning to school with a lot of problems that have been sort of like building up during COVID. And also our child psychiatrist just mentioning how often he's being called into the emergency room now to have to meet with kids and do an evaluation.
Trish.
I certainly would agree with everything that Tim said. I've had similar experiences. The focus of my practice is predominantly on trauma. And I think that I don't know anybody in the last however many months it's been now who hasn't been traumatized in one way or another. And I think one of the things that happens is that traumas result in a profound change, a fundamental change in how we think and even our ability to think. So that initially we have these spikes of fear and tremendous crisis. And the thing I heard all the time was, why can't I think? What's wrong with me? And this sort of, particularly after things like the fear of getting sick, or the loss of a loved one, loss of a job, in some instances, the loss of a small business completely falling apart or an industry disappearing because of the pandemic. But I think the other piece of it is that over time, those initial traumas and the impact on the way people are able to navigate their own lives have resulted in these really long-term stressors that seeing a huge number of cases of anxiety and depression in adults. I don't work with children, but I certainly hear about what Tim's talking about. And I think one of the biggest crises right now is that we don't have enough mental health providers. There are waiting lists at many community mental health centers. There are people in private practice who have no more space. And the problem is there are only just so many hours in the day. There's only so much work you can do. So it's taking a toll not only on our patients, but I think also on clinicians and the worries that we carry for them.
Eric.
Offered that the things that's worked for me is offering my patients the permission to see the negative impact on COVID, even if they are COVID negative and not having a single medical symptom, by offering to them decision fatigue can be the way of what Trish was talking about, is when to wear a mask or not to wear a mask, how far can I sit, what can I ask of the people I want to have dinner with, where am I going to be able to go safely and get what time of day am I going to groceries, or where am I going to sit if I'm going to go to a restaurant? Is it I know there was a New Yorker cartoon that spoofed it a bit, but there's is it the outdoor table, or is it the table that's outside open air, not inside and so there every permutation, and I'm deliberately stumbling over my own words to emphasize that the decisions that someone has to make, even just to make it to the appointment that they keep with me. Am I taking the bus and then the subway, or am I paying the money for the car? Am I doing this and riding the elevator or waiting for other people to not be in the elevator? All those micro decisions end up being anxiety producing and potentially, as Trish said, traumatizing. And so giving people permission to recognize that COVID had that impact on them, even with them not having COVID at all, I think helps begin the conversation toward healing.
Molly.
So one of the things that is, I treat patients at Sloan Kettering who are primarily on supportive care. So they are dealing with a cancer diagnosis that's already got them pretty much on a runway to what they already know is going to be their death within probably 6 months, pandemic aside. So the big piece of what I think the patients that I see deal with is a loss of support, or did, especially in the beginning of the pandemic, of just not having people in the room with them, not having their family, not being able to see people, not being able to express what they're experiencing without a mask on, people coming in with shields and masks. It's very isolating. So that's sort of an added layer to something that's already difficult. The other thing is that I think there are patients, and there are definitely patients that I see every time I'm there every day, who have not been able to go in and get screens because of COVID. And then they carry with them this idea that perhaps their cancer could have been mediated, or it could have been sort of dealt with in a more aggressive way earlier. And they're sort of working through an extra layer of stuff, whether it's true or not, that they are carrying with them into a very difficult metastatic cancer situation because of COVID.
Molly, I wonder if you and or Michael might be willing to talk about the spiritual dimensions of the COVID-19 pandemic and how this pandemic has affected the faith of the patients that you work with. Michael, if you'd like to go first. You're on mute though, Michael.
Yes, I would just like to say that the pandemic has created enormous stresses, spiritual and emotional distresses among patients and their families. And this has led some patients to question their faith, some to be angry with God, and it caused all sorts of different reactions and emotions. This has been exacerbated by the fact that many times, at least in the community that I was dealing with, multiple family members were infected and got sick at the same time. So you just added stresses upon stresses, and it became very difficult. I would say that that people's faith traditions and connecting them with those things that give them strength was beneficial and carried a lot of people through very tough times when they had family members that were lost or that were sick. And so it has been a time of deepening faith in some instances.
Molly, do you have anything to add?
Well, I don't really have, because of the nature of the patient's illness that I have, I feel like they have been grappling with the reality of a kind of existential edge to their life already. And somehow this pandemic has kind of like created a level playing field to like everybody, in this crisis moment. The patients themselves at Sloan Kettering who are on supportive care, who are really critically ill, are there. They are in that space, that liminal space of really cutting to the bone everything that is non-essential, and really living and looking at time in very, very, very new ways and very opening ways. And depending on sort of how they think, what gives them meaning, what they can lift their experience up to, whether it's somebody they love or something that creates joy or something that frames them, whether that's a religion or a creative a way in the world that they have. That's what we explore in those rooms, pandemic or no pandemic. The problem is that the COVID pandemic sort of isolated them from some of those people in their lives that really have given them that support. So it's even more important, the nursing staff, the clinical staff, the doctors, the chaplains, the social workers, the incredible group of people in the hospital that has been their family during the worst of the pandemic when they were grappling with these questions. And that's a difference.
We only have a few more minutes left, and in these final few minutes, I want to focus on you all. we've all been living through this COVID-19 pandemic. It has been traumatic for all of us, but you all, in addition to living through this pandemic, have had to care for people who are also living through this pandemic. And I'm wondering if you can talk about your own experience as caregivers during this time. Eric.
I would say it brought back, I'm sorry, I didn't expect to be choked up like this. Probably the week after New York on pause, I learned that 2 patients of our office had already died of COVID. And they had been patients that I hadn't seen them in my practice because I had gone from 5 days a week to 1 day a week, and they needed to move to someone who was more connected to the care there. And that really brought back to me my early days in HIV nursing of, wow, 2 in the space of 1 week. I am now on alert. My adrenaline level that I can't say officially PTSD, because that was not what it was, but it felt similar enough that I was going to have to really be mindful of being present for the next patient. And I needed to be there because that was important to them, and I needed to treat it with the seriousness that they were taking it, even if I was grappling with my own grief of losing folks that even if I hadn't seen them for years, they were a reminder of how quickly a pandemic can take hold of the entire system of healthcare. And it's only as good as the people who can make it work. And I wanted to make sure that I could stay present to do that.
Trish.
For me, it was a very, I don't know, I guess the words that come to mind was sort of a mind-blowing experience. I've worked with people when I've had stuff going on in my life that's meant that the work with other people has been very welcome. This was the first time I was experiencing exactly the same trauma that the other person was. And I found that to be challenging in a way that I had in the 25 years that I've practiced, that I've never been challenged. And I really had to listen to what I was recommending other people and remind myself that I needed to do that too, that I needed to take a moment of silence, that I needed to go for a walk, that I needed to connect with, my spiritual beliefs. And for me, that was often in silence, but it was, I think it sort of saved, I talk about it as like saved my mind.
Thank you both for that. I'm wondering how your faith sustains you all in the work that you do. Are there prayer practices? Trish mentioned silence and walking. Are there prayer practices? Are there other meditation practices? Are there scripture verses that you turn to? How important is your faith to you in your work? Tim.
I try and teach mindfulness to a lot of my clients, and I try and actually, use it myself. And that's something that's really helped me to be able to keep me sort of grounded in the moment and be more aware of, where I am and what's happening around me. I think that, for me, I was at the beginning of COVID, I was actually one of the lucky ones. I was on vacation for 2 weeks. And then when I came back, I had to quarantine for 2 weeks. So a lot happened in that month that I was gone. And one of the things that happened was St. Bart's stopped having in-person services. But what St. Bart's was able to do, and you played a big part of this, Peter, as far as the Rector's Forum, as far as the coffee hours, these different things allowed me to be able to kind of stay connected to my church family. And that's something that really, really helped me to be able to kind of get through this whole period of time. And things that I found that I was doing for myself, like Zoom meetings with friends on a regular basis, would be the things that I would be encouraging to try and my clients to try and do as a way of being able to maintain these connections. But for me, the connections that St. Bart's put out there really helped me to be able to kind of get through this whole thing pretty much intact.
We're very close to the end. I do want to ask one final question. Jamie, did you have something to add?
I just wanted to say, yes, St. Bart's has been a big part of it. For me personally, a small gratitude list at the end of each day has been hugely helpful, even in some of the worst times. We've got so much to be grateful for, and that just sort of doing that right before I go to sleep has been, for me, very beneficial, and it might be for others.
Thank you for bringing up gratitude. At the beginning of the pandemic, for several weeks at least, the city would erupt in cheers at 7 p.m. for all the good work that was being done in hospitals around the city and around the country and around the world. And we haven't been doing that for quite a while now. I'm wondering now how we can best support you all in the work that you're doing as members of the general public and as your patients. Tim.
Yeah, if you're not vaccinated, get vaccinated.
Jamie.
And if you are vaccinated and you have a friend who isn't, listen to them as to why they aren't. You may not be able to persuade them, but if it's like, well, I can't really get to a place to be vaccinated, then offer to go with them. But that's that, you know, just trying to connect to people who may still be hesitant, even if they can't do that. That connection, I think, is really something that will help us all as a community. So I would recommend that.
Well, thank you all. We do have to stop now. I want to add my personal gratitude to each of you for all the work that you do, and for all of the healthcare providers who are members of St. Bart's and all of the healthcare providers who are not members of St. Bart's, for all the work that you have done for all of us over the course of this past 18, 19 months, and the work that you always do for us. We are deeply, deeply grateful for your work. Thank you all for watching. We will be back in person and live with the forum next week. Mary Boyce, professor from Union Theological Seminary, will be talking about the relationship between Christianity and Judaism from its origins up until now. We hope that we will see you then, and we hope that you'll stick around for worship at 11 a.m. Thanks a lot.